something I like to start off with people in general is, from my perception, I feel like there's a lot of low-hanging fruit in the modern world that from a health perspective, or in your case, perhaps from a pain science perspective, that if people just started engaging with this activity or this mindset, or they just started implementing this thing in their daily life that's so obvious and so clear, you see it so clearly, but you feel like people are kind of, maybe not engaging with that. Is there anything that comes to mind that if we just started doing this thing, these couple of few things, it would make a big difference? It would be a long lever, would lead to great gain without much investment. Does that make sense, that question?
Yeah, I'm just, for me, I don't know if it's doing as much as knowing and thinking. I mean, our whole business is about reconceptualizing how people think about pain. And I mean, if people can just understand that pain is not, pain is a normal human experience, and without it, you wouldn't be here. We always see pain as an enemy, right? Pain means something's bad. Pain is there to protect us, no doubt. But I think, I mean, we right now are building a major, we've got 9 states that we teach middle school kids about pain. And if I can get those little kids just to go, pain's okay. The guy with the funny accent explained it. I'm going to be okay. And don't freak out about it. Then time is ready for me to go to, Shady Acres. I've done my job. And if we can get those kids to get it, Aaron, it'll change the world. There's no doubt in my mind.
I'd love to use this opportunity with you to do several things. One of which I think it'd be interesting to paint a picture of what is pain, and perhaps we could put it into, probably from your perception, lots of buckets, but at least the 2 baseline buckets of acute pain. I stepped on a nail, and mapping out like, what is that, from reaction up through spinal cord, up through hypothalamus or dorsal horn, or whatever the heck the terms are that I don't know what the hell I'm talking about, but I'm very curious to understand. And then the other bucket, and I'd be open to other buckets beyond this as well, would be that persistent pain where I don't really know why it's there, but it just seems like it's a part of my life, and I could do without it. So could we maybe start with like, what is acute pain in the body? How do we describe that?
I mean, acute pain is a normal response to typically an injury or an accident. It happens in a short amount of time. It's a protection. It's vital to survival. When you have an acute injury, you sprain your ankle, you step in a nail, there's got to be a warning system to tell you, hey, you need to take care of this problem. And so we activate nociceptors or receptors that basically fire a message into our spinal cord, into our brain, that tell it, hey, there's a problem. And the quickest way the brain and the body can get your attention is to turn on this thing we call pain. And so pain is there to protect us. It has a very useful job at this point. It's there to tell us, pay attention, there's a problem, pull the nail out, get a tetanus shot, put a bandage around it. And by the way, learn something from it. We walk around nails with shoes on. And so pain's not a bad thing. It's an acute phase it serves a beautiful purpose. You do not run the Austin half marathon 2 days post knee replacement. It's there to teach you, we're going to skip this year, we're going to try next year again. A beautiful model. I mean, Aaron, the flip side of it is people that cannot process pain. They're very rare. There is a genetic condition that has that. They don't live very long. And so people need to understand pain is a normal thing. It's okay. It's there to protect us for a certain amount of time. But then it should be going away, right? You step in a nail, take care of the problem, it eases off, and here we are. We're good. That's probably the easiest way to put it.
I feel like the questions I'm about to ask could lead us into like metaphysical circular weeds. But I'd be curious to define, where is pain located? Do you need a brain for pain? Is there some way to perceive pain without the brain? Is there exclusively physical pain?
Yeah. That last question was a loaded one, but the easy answer is physically, no brain, no pain. You can have an injury and no pain. I mean, you have gone in the morning to get a cup of coffee or something to drink. You notice a bruise in your body, so you had an injury, but no pain. Otherwise, you would remember the day, the date, the time that you hurt your leg. It's not uncommon to see blood on your leg or seeing a bruise. Injury and pain is not the same thing. If you really want to answer the question, what the really super, super smart people are telling us is that pain is a conscious construct of the brain. You need to be consciously aware. So let me flip it the other way around. If you can alter consciousness, you can alter pain. And we see it with anesthesia, with hypnosis, and those kinds of things. Now, the question you're going to ask me is obviously, what is consciousness? And I'm going to tell you that my pay scale will never reach the level of being able to answer. We don't know that. We just know it is subconscious, unconscious, etc. But it is a conscious construct of the brain, is the way we see it in neuroscience. It's when the brain puts value to it and starts paying attention to it, if I could put it that way. But you cannot have pain and not know about it. You can have an injury and not be aware of it. You and I could be sitting here today on this podcast, and I could have a really nasty low back on a scan, but I'm not aware of it. My system has decided, yeah, we're good. Adrian's on a podcast. Let's not bug the brain about it. But you cannot have pain and not know about it. Pain needs consciousness to be part of the realm. So,
and then what about the subjective? In advance, I appreciate you answering all these very like elementary questions.
No.
But what about the subjective experience of pain? Obviously, I'm never going to know what it's like for you to eat an avocado. So when you and so then within that, then there's been tons of research that you've probably actually conducted or at least been a part of, measuring the different scales of subjective pain based off of level of, I don't know, nervous system excitement, maybe you could say, or perception of what's happening.
Yeah. Well, first of all, every human being's pain experience is completely unique to them, bar none. There is no person that experiences the exact same pain as somebody else. And remember, this pain experience, though, Aaron, is not just this nociceptive information receptor sending a certain threshold and say, hey, you got to get pain. It's very powerfully linked to everything you believe, your upbringing. How did you experience pain when you were a child? By the way, it's tied to your culture, to what your zip code is. There are so many different variables to it. I think one of the biggest problems with pain, unfortunately, is we tend to judge people based on what's normal for us. I grew up a certain way, had certain experiences that makes pain a certain threshold for me. You walk into the clinic or in the research lab and you express it different, doesn't make it wrong, it doesn't make it right, it just makes it different. And so we tend to judge real quick. Some cultures are very stoic when it comes to pain, and other cultures are more expressive. It doesn't make it wrong, it just makes it different. In my world, I get brain scans and stuff here around me, and the research we're doing, I don't own a painometer. You cannot walk in my clinic today and on a scale of 10, tell me it's 7, and I buzz your back and go, it's only 5, you're lying to me. Pain is a subjective expression of how this experience is affecting my life. And how dare I, as a provider or any person, a family member, a friend, a colleague, judge you on that? How do I know that? I would never know. That's what makes it so hard, right? To treat pain, if you will.
Yeah. I feel like this is eventually, this is where it starts to go into the weeds, but I think it's interesting, weeds, is I wonder if there's some type of cultural preset that would be the most adaptive or supportive for a person having a healthy, in quotations, relationship to pain. And the reason I say that is there's some people that you may have been exposed to. I've been exposed to a lot of them because I grew up, I've lived in a lot of like new age meccas. I lived in LA, lived in Hawaii, lived in Boulder, Colorado. And within that, there's this ongoing kind of like repetition of doing the work, and I think that you can place yourself into a mindset where you're just in the place, if you're always just digging up the muck, you're never not digging up the muck within yourself. And you can go your whole life just finding out, well, this muck is endless. And then there's the other side of the spectrum where you could be a person where they're completely numb and they're more stoic, and maybe they grew up in Armenia or something, and they can bear a lot, but there's a lot of untapped emotion and sensation within. And I feel like there's nothing, I don't know, I've never been to Armenia, but I feel like there's some in-between space there that would perhaps lead to the most, I don't know, adaptive relationship to sensation, I guess, for lack of better words. Is there some type of, do you know what I'm saying? Is there any sense to that?
I know exactly what you're saying. The problem is just, it's not that easy. It's a very strong interplay between genetics, cultural upbringing, previous experiences, coping skills, all those things. If I can go another way, Aaron, if I flip it the other way around, I get 2 kids. If I could, of all the research I've looked at, if I can extract one thing to give my kids to, for lack of a better term, immunize them, which you shouldn't, right? Pain is normal. We should be there to protect us. I think all the data would point to things like coping strategies. We all experience pain. It's a normal human experience. I cannot prevent pain. I hate it when I sit on a scientific panel and say, our next speaker is going to talk about how to prevent back pain. You cannot prevent back pain. Back pain is a normal human thing. What you do about it is very, very important. And that's where that's the squeeze. That's the important part. Some people hurt their back and they go in a life of pain. Another group of people hurt their back and go, I'm good. A couple of stretches. I lay low, I'll do a few, stretches a therapist showed me. I'll do a little bit of yoga and life is good. And they move on. And it's self-efficacy, it's coping skills. There's something, and it's a combination of so many factors, including upbringing, culture. Yes, it's very different if you sprain your ankle in Beverly Hills versus spraining your ankle in a war-torn area in Syria right now. It means two different things in two different areas with environment, culture. It's a very complex human experience. Yeah.
What about, where does pain live? What's the best shot we have in like anatomical language at isolating the existence of pain within the brain? Is there some structures that are more prevalent in the conversation, at least?
I mean, we can now take human beings and scan their brain when it comes to pain. And I just want people to understand that, in these brain scans, we're inferring a lot. We are guessing a lot. Because it's really, when we scan you, a certain area of the brain will get busier. There's more oxygen, more glucose in the area, and the scanner will pick that up. But we don't know if that area is suppressed or elevated. It gets a little more trickier. I just want to make sure I put that out there. We do know that there is a common pattern or a common mapping that occurs in all human beings. So if I had 10 errands standing in front of me, and errand number 1 is back pain, errand number 2 is headaches, number 3 is an ACL injury, put them all together, there are commonalities, yes. And we tend to find that when the emotional areas like the amygdala gets involved, it gets trickier. Hippocampus with memory and all those. But I just want to caution us, because medicine did this for the last 300 years to find that one little area can go cut out tomorrow because I'm an American and we got to fix it tomorrow. And while you're at it, supersize it. It doesn't work that way. This is an experience. It's not an anatomical fault. It's not that some people, their amygdala is wrong, so we cut it out or we inflate it or whatever. It's still a human experience. And so I'm always worried about those areas. But yes, if people wanted to know where they should look, we do know this. Let me tell you this. If I punch you in the arm right now, those areas in your brain will all work together. But if your pain persists over time, more of the attention shifts to your limbic system, your emotional areas of your brain. And so that seems to be a big target of our research, is to aim towards the emotional areas of the brain, including the amygdala as an example.
So interesting. And then how does pain how does acute pain, which seems very adaptive, supportive, if you're born with, I think it's called congenital analgesia, I think is a term for it, where you're born, you don't feel sensation. It's actually like an incredibly dangerous situation and you're not going to be long lived in that. So it's coming into a relationship like, oh, pain, like amazing. What is the timeline or narrative or story or transition from what was once acute supportive adaptive, still probably supportive adaptive, but now into this kind of murky, nebulous, chronic state?
Yeah. Well, I'm glad you brought the word time in, because the research is shifting. Up until probably about a year and a half ago, Aaron, I would tell you, if pain lasts from the day you sprain your ankle to a certain period of time, we will classify you as acute. And if you wake up the next morning, you move into the subacute and then later chronic phase. It's a timeline. By the way, the timeline is different in America than in Europe. In Europe, the timeline is 3 months. In America, it tends to be 6 months, which is, that in itself is just intriguing. Chronic pain is really probably pain that is beyond the normal phase, adaptive phase of having a biological need to protect you. Now your system is adapting accordingly. So basically, it's pain that lasts a little bit longer. It is now actually, it did not go away. It did not ease as we expected. And now it's that's why we like the term persistent pain, because persistent just means it's ongoing pain. And to answer your question real quick, it's a little trickier than time. For example, we now know if 10 people today are in a motor vehicle collision, there's a small group of them that may already be set up for persistent pain within a couple of days. It's not a timeline thing that, it plays a role, but it's a little trickier than that. Chronic pain is where your nervous system, your whole nervous system, 45 miles of it, your spinal cord, your brain now starts getting more upregulated, sensitized, and become more hypervigilant to normal things. And that's where the pain system shifts, if you will, to people, that it becomes a little bit more yucky over time.
There was an interesting, I was recently listening to, I don't know where I got this from, but story of a fella, some construction worker. You probably know the specific details of this. I think it was like I don't know, it was a while ago, maybe decades ago. Stepped on a nail, went through his boot. Do you know the story I'm talking about? Yeah, so he stepped on a nail.
British medical journal.
Yes, yeah, stepped on a nail. So now I'm going to butcher the story, that you can come back and actually describe how it really happened. But generally, long story short, stepped on a nail, went through his boot, agonizing pain, wigging out. They move it at all, just like the worst pain ever. And then goes to the hospital. Finally, they slowly extract the nail in the boot, and they get ready to, proceed with their procedures. Nail never touched his foot. Went through the boot, so he had the perception of this experience, and his pain was real. But the objective reality of the action was different than his perception. That's so interesting. I feel like that's like a foundation for the whole conversation in a way.
Yes, but this is it. I mean, Aaron, for too long we've tied tissue health to pain. If you have bad tissues, you hurt. And if you have healthy tissues, you cannot hurt. And that's total nonsense. This is a beautiful story that they published years ago. But the story idea that from the visual perception that he's getting, the brain constructed its own reality. The reality for his brain is that nail went through my foot, there's tissue damage. And now when you touch it, it's irritating. And so it causes the most horrific pain. But the reality is the nail was stuck between two toes. So pain is a perception of the brain based on perception of threat. When the brain perceives a threat, it will protect you vehemently. And the scary thing is, in some people, light movements or barely touching their skin is perceived as a threat based on things that have happened to them during their course of an injury, an accident, surgery, or life experiences. But the brain is by far the key. If the brain perceives there's a problem, it'll protect you. And the most valuable thing you can do is turn on pain.
So what are your thoughts on, I've heard you describe maybe like 3 steps or 3 pillars to gaining a relationship with sensation, i.e. like relieving pain. And one of the factors that you've described in the past, maybe they've changed for this point, but one of them is education. So educating a person of like, okay, this is normal, this is okay, this is, however, whatever, I'd be curious your language for presenting education. And then where the question goes, I think I've heard you kind of poo-poo a little bit on not specifically John Sarno and mind over back pain, but the general concepts around that. It seemed like there was some poo-poo on the idea that you could like talk someone through or educate someone through pain to dissolve pain in an instant. What are your thoughts on that?
Yeah, I'll have to go back and find out where that would come from because, just simply stated, our research work is something I refer to as pain neuroscience education. That is taking a human being that is struggling with pain and explaining to him biologically how pain works. And when they understand what's happening to them, the fact that injury and pain is not the same thing, the fact that a part of your pain experience is where this nervous system, or we call it the alarm system, is becoming increasingly sensitized. And so when you are trying to do an activity, walk, run, do whatever task you do, the sensitive alarm system is one of the barriers that you're struggling with. And what our research has now shown via just tons of research we've done is when a human being sits in front of us and they learn more about their pain, how their pain works, their life is better for it. And including, by the way, Aaron, the pain goes down. So I'm not poo-pooing any idea of education. But the critical thing is education by itself doesn't change behavior. We as Americans spend $2.1 trillion a year telling people smoking causes cancer. And only 1 in 5 people go, yeah, I should probably stop smoking. What I am concerned about is people think you can just talk pain out of people. It's not that simple. I've been doing this for 30 years of the smartest people on the planet. I maybe have had 5 people in our clinic that after teaching them go, oh my gosh, I got it. And they bet, no, what are you doing? You're changing their fear and catastrophization, meaning they're not that afraid to move. And then they start moving. And what made them better is actually movement. We know that movement is by far the biggest painkiller on the planet, by far, but people in pain won't move. Why? They're afraid. They're nervous they're going to make something worse. And when you explain to them that feeling your arm, feeling your leg is normal, it's part of this pain experience, it de-threatens it and they move. And so I just want to make sure I'm not poo-pooing anybody. Dr. Sarno has done amazing work and He's a very well-respected gentleman. Has done an amazing amount of work.
You weren't pooh-poohing Sarno. You never said anything John Sarno. Okay. And I think I'm probably misremembering something I listened to like a week ago. But it was something along the lines of it. I think kind of like what you're saying. It's like you also, it's like education, yes, and is I think kind of more where you're going with it.
I can tell you straight up, it's easy. You cannot explain pain out of a person. I've tried. Okay, it doesn't work. You can teach people about pain so they become less afraid of it, and then they start moving, engaging in daily activities, getting back to their life, and that is what makes them better. And so education is important. There are millions of people that go to movement-based professionals every day, PT, chiropractors, athletic trainers, personal trainers, yoga masters, you name them. But they won't recover fully because they're so afraid to move or to commit to that next level of movement, because they're so afraid of their pain. All we've done is we've just taught people more about pain so they go, I got it. I understand it. I don't have to be afraid of it. So when I do go see my yoga master, my Pilates instructor, my physical therapist, my occupational therapist, whatever it may be, I'm ready to engage. And that's what gets them further along that path. That's, I think, what paraphrasing probably more of what I was trying to get to with people. But if I could just talk pain out of you, it'd be very simple, right?
Yeah, I feel like I'm totally misrepresenting what you, and it totally like shifted in my mind of what you said. But so for from like a clinician's perspective, or just a mother's perspective or a friend's perspective, if there were some foundational bullet points to share to support someone's relationship with the sensation that they're experiencing, to create a foundation for understanding and education, what would some of those foundational bullet points to share be from your perspective?
I mean, the most common thing when patients come in, we explain to them, first of all, we validate. So let's use an example. A mom walks in our clinic today with her high school volleyball player kid that just sprained her ankle. I would validate this kid and say, you sprained your ankle, tissues do get injured, there's a little bit of irritation, and that's why your ankle is painful. And we got to get you moving. But at the same time, the nerves around that area that works like an alarm system has ramped up and said, ding, 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 go see Adriaan. And when we do therapy, we need to get your ankle better and healthier, but also calm your nervous system down, this alarm system. So now we start including things like you're sore but safe. So when that girl does some exercise in the clinic and she walks on her ankle that afternoon, are you sore? Yes, but you're safe. Hurt doesn't equal harm. Just because you feel your ankle doesn't mean there's something invariably wrong with it. It's still sensitive. The alarm system, if you will, has to calm down. So it's a dual model. And by the way, for the calming of the alarm system, it opens up avenues for things like sleep and nutrition and exercise, mindfulness, relaxation, which is where we should be going with some of this stuff. But if I can get people just to understand you're sore but safe, hurt does not equal harm. Pain that is understood is not to be feared. If you understand your pain and go, I got it. Yeah, I'm sore today, but the guy with the funny accent explained, I'm going to be okay. I am, you can move accordingly. That's where we go with a lot of the analogies with our patients.
Yeah, it seems like being like safety and having the illusion of control is really important, because ultimately, we're illusion of control. I say because we're being flung through this place we called space at 22,000 miles an hour, or whatever. We're just like, how much control do we really have? But so it's the illusion of control that I think it seems like that presents a big shift.
Yeah, it's funny because the top behavioral psychologists in the world will tell us patients in pain are not afraid. They just lack safety, which is not the exact same thing. But it is. If you can give somebody safety, you're safe to move. You're safe to move a little more. You're safe to move today. And when you come back tomorrow, we're going to move a little bit more. Safety is important for us because as long as we're not safe, the brain has 86 billion neurons and they're sitting there talking to each other and they have to analyze, am I safe? If I'm safe, I can turn the alarm system down. If I'm not safe, we're going to ramp this sucker up and we're going to make your life miserable until we get safe. And so I love your analogy. Absolutely. Safety is a very cool thing in any healthcare provider, a parent creating some safety for my child, and a trainer that getting somebody, it's safe to move up to this point and then just stop there. You're good for today, good for tomorrow, and those things. So I love your analogy, yes.
Yeah. And so then I'd love to get into one thing that I think is interesting as a concept is the pain gate theory, and how we can kind of, and maybe that's just nonsense for even suggesting. So I'd love to hear your perception on that. And the reason I suggest that is to come into the next, what I'm deeming to be a pillar or step, would be the movement conversation. I see you squinting your eyes. You're like, oh no, pillar steps. I hate all this language. But so movement, why is movement relevant, and what is pain gate theory? And is pain gate theory malarkey from your perspective based off of your reaction?
No, I mean, in 1965, Melzack and Wall gave us gate control. It was one of those fundamental shifts in our understanding of pain. But you need to understand today that we are now, 50 plus years beyond that, 57 years later. And if you're sitting in 2022 and we're thinking that's still the pinnacle of treating people in pain, then we should not be here today. Gate control has its time and its place, but it's a very peripherally based model. If I'm going to take your question and flip it the other way around, the most incredible things we're seeing related to movement and pain, Aaron, is not gate control related. It is endogenous mechanisms related. Your brain that starts turning on its own chemistry. Our brains produces opioids 50 times more powerful than what you can inject in a human body. This is the most powerful drug cabinet on the planet sitting between your ears, and it's all naturally occurring. And one of the best ways to turn it on is movement. I'll give you an example. A 6 mile run produces 10 milligrams of morphine in your brain. If you break your arm today and go to the ER, they're going to give you a couple of milligrams of morphine to set your arm and put it in a cast. You can get 2 or 3 times that running 6 miles. Now, we cannot take somebody with chronic pain to go run 6 miles, but we start small and we build over time. I mean, but the effectiveness of movement and pain is not stimulating some fibers that's closing a gate. That is so 1965. The 2022 answer is it turns on your brain, it turns on the chemicals, endorphins, and enkephalin, serotonin, the happy juices, and just says, you know what, we're good. We're going to calm the system and move. That's where the excitement comes from with oxygen, blood flow. That's way more physiological than just receptors that are overstimulating.
My perception of pain gate theory would be something more like it would be more acute related pain. So you do stub your toe and you like go and you like run. That's what pain gate theory is. Is that correct?
It's a piece of it, absolutely, right? And gate control is very simple. I mean, the easiest way for gate control is you bang your elbow against the coffee table and you rub the area. You're now stimulating different fibers that is overriding, if you will, the signals that are associated with banging your elbow. And so rubbing an area, walking it off those kind of things. But the interesting thing is all these things, rubbing the arm, walk it off, kind of get going, also enhances the endogenous systems that are so more powerful than a simple receptor. So if you really want to go gate control today, gate control does not explain pain in phantom limb pain because there's no foot, there's no leg. It doesn't explain pain in quadriplegics and we even go to emotional pain or abuse, trauma, those kind of things. So it's way more complicated. And by the way, Ron Melzack, who passed away recently, was one of the founders who made that model. In 1999, wrote a paper that basically said, for the love of God, move on. This thing is old. It's 1965. And he came up with these new theories. So I'm not disparaging towards Patrick Wall and Ron Melzack. These are some of our highest regarded people in our field, but it's way cooler than that. How about that? It's just way cooler than just.
So what I'm what I'm getting from that is it seems like the gate theory stuff is a reduction of something that is happening, but an incomplete story.
It's just a piece of it.
Yeah.
And I would just encourage people that if that's the only way they want to look at pain, go for it. But you're 57 years behind us. How about that? So wait a minute, Aaron. In physical therapy school, as an example, we still teach kids, students to put on a TENS unit or electrical stimulation that also stimulate fibers. And will it help people? Yes, it will. But it's a piece of the puzzle. It's not the puzzle. The puzzle is way better and cooler that we can now tell the story way more advanced, if you will, than just simple fibers. And there's a big, strong belief about this. I'm not disparaging that model. It was revolutionary in 1965.
So it seems like there's like a pharmacological, like an endogenous pharmacological model that's missing in the gate theory perspective. Is that? By the way, I have no idea what I'm talking about, and I'm just like curious. And so anytime I say something that's absolutely just outlandish, you just like nod your head like no, Aaron.
No, it's fine, and I'm okay. I mean, as many of your listeners would listen today, they're probably very familiar with gate control. They should be, but it's a very reductionist, peripheralistic way of looking at pain. Pain is way more complex than that, and we have way cooler tools to address it from the central mechanisms. How about this? It's there's a beautiful idea of bottom up and top down. And what I mean by that is if you have a painful shoulder, let's do stuff from your shoulder in. And that includes gait control. Let's get that area moving better, blood flow, oxygen, and also calm the system, but then also centrally, taking away fear, anxiety, catastrophization. So it's a little bit of both. I don't want to negate peripheral factors in pain. They're very powerful, but they may not be as powerful as we said way back in the 60s, 70s, maybe even 80s and 90s. That's all I'm saying. So I'm going to have to be one of those scientists that say, you know what, gait control is awesome. I will still teach people about it. But if you only believe that, then I'm going to have to leave you behind because the world is way cooler on this side.
So what I know you've already talked about, but can you kind of fill in the rest of the puzzle then? So if gait is just one of the reductionist perspectives on it, there's like what I'm deeming the pharmacological aspect of like the natural production of opiates and things of the sort. But again, like what's the rest of the puzzle?
Well, the rest of the puzzle is basically, so you're going to get information coming in from your tissues, right? Your tissues have receptors all over them that will tell you it's too hot here, or you pinch something, you damage something. So there's information coming in. Let's call them danger receptors saying danger, danger, Aaron, there's something going on in your ankle. Your brain will then have a meeting. That information, by the way, comes into our spinal cord, up to our brain, to the thalamus, which works like a receptionist, if you will, that takes information and holds a meeting. Your whole brain then gets together, takes a meeting, and then decides, is this a threat or not? And if it decides it's a threat, it'll dry up the happy chemicals in our system to make you more sensitive. And if this decides that it's not that big of a deal, we can be okay, it lets these chemicals centrally come down, enkephalins, endorphins, serotonins. There's various areas in the brain, like the periaqueductal gray, that we can turn on with some of these treatments that will actually calm the system back down. Way more complex than that stuff, but yes, it ties very powerfully into those centrally acting opioids, enkephalins, endorphins, along with
So what's interesting there is something that a person could do would be maybe like hyperventilate themselves, do some type of pranayama, huffing and puffing, breathwork type practice, and that will desensitize them to doing something like a cold plunge. And a term that I've learned from that is stress-induced analgesia, which would be comparable to like you're in a fight and you don't feel anything. And so you're so stressed that you're actually surged with all of these, whatever, opiates, for lack of understanding of what's actually going on for myself. I'd love for you to fill it in, where you don't feel the thing actually because you're so stressed. So where does that come in?
That's a good question. I think we deal with a lot of different things. You're talking here about distraction in some way, shape, or form. If you're doing something else, your brain can only really focus on one thing. The interesting thing is you cannot process more than one pain at a time. So if I were to have you pinch your face right now and at the same time bite your lip, your brain could not do both.
Is that gate theory?
That's not gate theory.
That's not gate theory.
That is not gate theory. There will always be a gate element or a peripheral element. But it's the brain it has to switch between those two components. But that's one piece of it. Let's go to the other part of it, right? We work with soldiers that get in the combat zones, that get shot, but they are so aware of where they're at and survival mode that this injury that comes in, let's say somebody gets shot in an arm, information comes in, the brain gets information, hey, something's going on here, but it's in a survival mode that it will actually shut that area down. And that's called inhibition. The brain is just turning on these incredible endorphins and just saying, shut it down. I got to deal with bigger things right now. There are bullets flying around me. I got to get out of this area. And then when they do come back out of those zones into the safe areas like the green zone, and they sit down and notice, hey, it's wet. What happened here? Oh, I get shot. Right? We see it with injuries quite often. You see on on TV, the MMA fighter that at the end holds up his belt. I won. And then, meanwhile, one of his toes is facing 90 degrees in the wrong direction, because he's so busy with those. And it's interesting, the brain can decide to pay attention or not. And a lot of this, by the way, Aaron, is driven by these chemicals, where the brain can decide to shut an area down or to pay more attention to it. But again, as far as cutting the line between this is gate, this is not gate, I'm not going to go there, because we're one big biological system that does not work in pieces. We work beautifully together as a symphony. All I wanted to make sure you and your audience understand is, if you had to invest somewhere, I would invest in the central nervous system with the chemicals, because that's where the bang for the buck is, no doubt. Because if we can change those chemicals, that's where we can change the painful experience very easily.
So how do we invest in the central nervous system and those chemicals? I mean, you're already explaining, but like what's the takeaways with that?
Yeah, I mean, we have my research team and I have looked at the last few years. There's about in my profession, there's 22 different things that we do on a daily basis that turns those chemicals on, that empowers the pharmacy, right? And this is things like knowledge, things like movement, mindfulness, breathing, nutrition, sleep hygiene, I mean, the list goes on and on and on. There's so many cool things that can get this brain turned on. Why do we give people with persistent pain antidepressants? Because they're depressed? No. Low dose antidepressants turn that chemical on again, but it does it pharmacologically with side effects. We have just decided we're going to try and turn the brain on non pharmacologically. And we have good research to prove it. I can show it to you in the brain scan studies and all the stuff we've done. But if you start getting people to understand what's going on, they got goals, they're not afraid of its safety, like you mentioned, and now they start moving, they sleep better, they eat better, they spend some time on purposeful mindfulness practice, goal setting, and these really amazing things that are non-pharmacological. The system can turn itself on. We just published a paper where a physician was able to taper people off opioids completely by turning their own natural system on, and that's what we're trying to do.
And so, what are cases of pain that have stumped you? Like, what's the hardest question for pain for you?
How much time do you got? I mean, every patient's unique. You said it in your first part of the interview today. Every patient walking in, there's patterns that we see, right? Certain patterns that we see, you get comfortable, but let's face it, there are some significantly serious pain conditions out there in my realm. And again, all apologies to anybody listening today that practice in just completely different settings or whatever. But things like complex regional pain syndrome, where you get conditions like allodynia, where you get pain from things that shouldn't hurt. Light touch hurts, thinking about movement hurts. So pain is a spectrum, and we do see people on these end scales there, Aaron. And there's many of these patients that have to go to very advanced pain centers and very horrible pharmaceutical interventions and surgeries and drugs and those kind of things. And so, but pain is a nasty thing. Make no mistake about it. I don't want people to think this is just little ankle sprains here and there. Today, as you and I are sitting here, there are some people struggling significantly with pain today because they're on the end scale where their system is now so sensitive that anything related to movement, function, whatever, is a threat, and the brain is on full alert at this point.
I'm recording with Larimer Mosley. Larimer, yeah. Larimer Mosley coming up. And I heard you mention him. You guys work together, it seems, right? You're like...
Yeah, I did. I worked with Larimer for about 7 years or so. We do research in the same area. Super brilliant, smart. He's about... you should ask him the consciousness question, by the way, because I think he can maybe answer. You ask him what consciousness is.
Okay.
And then just give me a phone call. I got your phone number. Call me, let me know. Oh no, Lorimer is a brilliantly smart guy. I mean, I've learned an enormous amount from him and still do. So absolutely, I'm very excited for you to talk to him because you should. People should be listening to what he's
saying. One of the things I heard you mentioning in relation to him was that he suggested that he's attempting or interested in working on the hardest problems and working his way back from there, such as the complex regional pain syndrome. And is fibromyalgia, is that the same, or are those different categories?
They're different conditions. They're very different conditions, but still extremely challenging. Affects a lot of millions and millions of people are affected by it. The underlying mechanisms are very different, and their clinical presentations are very different. CRPS is more localized, for example, in a hand or a foot or a body part. Fibromyalgia is more of a widespread pain that is driven very extensively by things like the immune system, etc. But they're both very challenging, and they both affect human beings immensely in their daily function.
So what could we learn from an allodynia? And how do you define allodynia? That exactly as well.
Allodynia is just when you experience pain from something that shouldn't hurt, by touch, thinking about movement, like the air conditioner hits my arm with cool air and it produces a pain response. That's allodynia.
Thinking, reversing our perspective, going backwards from the complex regional pain syndromes and the fibromyalgias and the allodynias and the things it's like, oh, these are like really hard problems. What can we learn from those to inform the knee pain or the back pain from your perspective?
Yeah, and so for those patients, first of all, we always thought of education. We have now good studies to show if somebody walked in a clinic with CRPS, we explain to him or her what's biologically happening to the body. Why is light touch now painful? Why does the shirt hurt? And they understand that their threat level goes down. So they actually get better. Are they fixed? No, we're not even close there. But then we start doing other strategies. Now, for CRPS, we use a very specific program called graded motor imagery. Aaron, where we actually target some of the mapping in the brain. Our body parts are mapped in the brain in certain parts of it, and those maps get altered in pain experiences like CRPS. So we have a sequence of events where we can actually retrain those areas of the brain to help with pain. And so we can use things like virtual reality, mirror therapy, motor imagery, retraining left and right recognition. So it's just an advanced series of brain techniques to restructure how the brain sees those body
How
parts.
do we leverage, I guess we're always leveraging neuroplasticity, whether we realize it or not, whether it's, for betterment or detriment, but how do we start to gain how do we leverage neuroplasticity to our advantage? And what is neuroplasticity in relation to pain from your experience?
Yeah, so let me answer the first one, the second question first, and then work the other way around. In our brain, we have a representation of our body. There's a right hand, there's a left hand, the whole body is represented. And these maps, all we have to know is they're dynamically maintained. If you use a body part a lot, the map is actually pretty sharp and crisp. If I showed you a picture of my hand, you'll tell me it's a hand, it's not a foot. I'll show you it's the right hand, not a left hand. So you use that mapping. It's the same map, by the way, that if I ask you to close your eyes and touch your nose with your index finger, you would do, because that map is still alive. When we develop pain and we don't move much, or we're afraid of pain, or our hand is in a cast or a brace, that map isn't exercised. These maps need to be exercised all the time. And when they don't get exercised, they become a little blurry, if you will. We call it smudging. And when the brain gets worried about your hand and your foot, and I'm paraphrasing, it'll turn up the dial on the alarm system, making you more sensitive, more sensitive, more sensitive. So now things like light touch could actually become uncomfortable. We then do a series of techniques to actually sharpen this map. So do you know what's left and right? That this is a hand, not a foot. And when a map gets sharper, it eases the pain. And what does this mean to me and you? CRPS is a very rare condition in the big scheme of things, Aaron. But we've now taken this kind of mapping training to more common conditions like back pain, knee replacements, rotator cuff injuries, which people are coming in by the millions for treatment. And when those maps sharpen post-operatively, when they're afraid to move, it dampens it down. We can now take school kids. We did a study in Wyoming where we took school kids before basketball season, measured some of these measurements, right? How quickly can you pick up left and right? How accurate are you? And we could almost predict to the kid who's going to sprain their ankle this year, right? So there's all these opportunities that we can see. Who's going to do well in operations? Who should we be careful with doing operations? Who should we do more strengthening, conditioning before they start the basketball season or whatever? So there are some opportunities. And because the brain is plastic, we can retrain it. And I think that's where that term is probably, and by the way, Lorimer will probably talk more about bioplasticity than neuroplasticity, because there's plasticity to the immune system, the biology, everything's plastic in our system. You're not stuck that way. That's not the way you are.
I love the concept and the term smudge, because I feel like that, like, we all have a different, I don't know, a relationship to our sense, like a sensory motor relationship, and some people have more. It's like a person that understands astronomy. They can look up into the stars and see, oh, I see black holes, and I see Jupiter and Saturn, and I see, like, I can feel gravity and 9.8 meters per second. I have this, it's like elaborate story just by looking out into space. We have that with our plantar fascia, and we have that with our, the orientation of our pelvis and our pelvic floor and our vocal cords, and a person that can dance, or a yogi, or has some type of breath control. And those are all mapped in the brain. And there's portions, of our motor system that can have this, like, to use that language, like a smudge of sorts. And I think it's a really interesting, and I might be misspeaking for things, so please correct me, but the process of filling in that information in there, it's almost like a blank page in a book, and the book isn't complete, is maybe perhaps an analogy. So the book doesn't really make sense. It feels confusing to read the book. It feels confusing to be in the body, in a way. Like the process of filling in those spaces. There's a book that I know that you're a fan of, called The Brain That Changes Itself by Norman Deutsch. That it just gets into, like, countless examples of how plastic, this brain really is, and the level of change that we're capable of. Can we talk a little bit about the process of starting to fill in some of those smudges? That's probably not the right usage of language. Please correct all of that for wherever misrepresentations were there.
No, I love your analogy. I love the idea that the book is never written, right? Every day is a new day for us. And your brain has 125,000 miles of wiring, gets replaced every 3 weeks. So this thing reinvents itself every split second of every day. Again, Aaron, I can only speak for the area I'm involved in, but we know that movement, just keeping moving, movement is a critical element of it. The minute you stop moving, the maps don't get exercise, and they do smudge. That is motor and sensory maps as well as immune maps. So they constantly. So we're very keen on the idea of movement, getting people moving, getting tactile information into a touch is important. It's just the idea of things like walking barefoot, getting sensory feed into the system. We've done so many things about getting rid of these things, right? We have stiff, rigid orthotics. I mean, older patients, we're getting ready to do a study in a nursing home where older adults are put in stiff, rigid orthopedic shoes. They don't know where their feet are. And so if you take those out and just having them start walking barefoot and say, wow, there's my foot, there's my big toe, there's my little toe, and it starts feeding. So the more sensory feed we can put into the system through movement, touch, sensory experiences, those kind of things I think are absolutely vital. We're doing a lot of that in our research right now to try and alter these maps as well.
I would presume that in a lot of ways, Homo sapiens are at a all-time low of sensory input. There's a sensory deficit. Whereas, forever in our ancestry, we'd be exposed to varied temperatures and varied light cycles and threats and, different ranges of motion and, different textures on our feet and such. What we've done in the last, whatever technological history or agricultural, industrial, whatever, we've kind of placed ourselves into these flat planes. And most of the information relationship that we have comes from these flat, cell phone blue lit screens. And it's just, everything's kind of the same texture. It's just flat and, whatever, it's just flat. Do you think there could be anything to that, like the removal or like a sensory deficit of sorts that could be contributing to the experience that perhaps some people are having with pain?
I don't think it's lost on us that not many people wear food and those. I mean, that yes, I'm with you. I just tend to not look at the world that way. I mean, I tend to look at more that we're changing. When we talk about cell phones, we talk about tablets, TVs, whatever. I think we're getting enormous amount of information, but just different. We're now getting, obviously cognitive and screens and all that kind of stuff. Could it be that 50, 100 years from now, when we do these brain scans, that the maps have altered so much and they've adapted to screens and computers and stuff, and the legs are smaller because we don't walk barefoot and whatever? I don't know. I'll find out like you maybe one day. I'm with you. If you just want to talk about specifically like things like, yes, we have some sensory deficits. It's intriguing because with kids now, there's all these sensory toys. It's making a big comeback. I mean, I should have invested in it, I think, because suddenly it's a new hot thing. People have all these sensory. You may be very much onto it. Absolutely. I just wonder if things are just changing, right? We've gone from a certain type of living into a different kind of living, and I don't like the idea of saying always it's a bad thing. It's different. It's just different.
What kind of practices do you engage in with yourself to keep your body? Do you have much pain in your body?
I'm an old guy, so yeah, of course I have pain.
Wait, hold on, back up. Was that a story that would like a self-fulfilling prophecy? The concept that I'm an old guy, so of course I have pain?
No.
No.
I was just going to see if you're paying attention. No, I'm no different than anybody else. I mean, by the way, you're going to talk to Lorimer. There was a Lorimer had a discussion, a blog years ago, that he had horrific pain, and the whole world had to go at him because they said, "Wait a minute, you, Mister Super Pain Guy, if you know so much about pain, how come you have pain? Because if you understand pain, it's not that simple." So yes, I have pain. There's days I have pain and whatever. But one of the things I do revel in is the fact of how I was trained by my parents and my upbringing. Strong coping skills, ways to deal with it. I'm way more task driven than pain driven, meaning I got to get it done. Those kind of things. So yeah, I have those as well. When I have pain, I would do what everybody else does. I slow down a little bit, take care of myself, avoid some activity for a little while, but I keep moving, focusing on where I need to go and those kind of things. But I would definitely go more in behavioral realm in this regard. I'm not genetically gifted to not have pain or have less pain than other people. No, I just have learned very good coping skills. And this is, by the way, pre science, pre-PhD, pre-studies. This is just dad telling me, suck it up. We got to keep going. We got things to do on the farm, right? And playing rugby where there's no pads and helmets. And so I was very privileged to learn really good experiences with pain in my life.
Yeah, I feel like I've had the experience. I feel like sometimes in my life, if I am really engaged with life, it's almost like I don't have time for pain, or I don't have time to get sick. You know, like have you ever had that experience in a way where it's kind of like yeah, things can happen,
Yeah.
but like I don't have space for that right now.
And the behavioral psychologist would say you're just very task goal oriented, and that is actually part of it, though, Aaron, because people that migrate towards the pain side become very obsessed and focused on the pain. It takes that much of their space. People like yourself, me, and I don't want anybody in pain today to think that, oh, great, yeah, these guys are this. No, pain is horrible. It's a terrible thing for people. But if you are focused on goals, getting to where you need to go, those things they tend to do way better, and that's what the models are showing us by far. Yes.
Is there anything that you feel like when you do interviews with people like this, is there any topics or directions that you would like to go that aren't touched on? Is there anything that's like kind of like, oh, like I'd like to talk about this more, but people don't really ask about it?
No, they always go the same way. I mean, it doesn't. I'm an open book. I can go in any
Well,
direction.
what's surprising to you? I don't want to go the same way. Is there anything that's like what are you scratching your head about?
What am I scratching my head about? Oh my goodness, that is a good question. Ooh, what am I scratching my head about? I mean, I have the same problems. I mean, it's funny. Yesterday, I met with a big insurance carrier. Won't mention their name on yours, but basically just like, you know what, we're doing all this incredible research, all this amazing stuff, but you guys aren't, paying attention. You're just more focusing on drugs and surgery and the medical route. So we have big fights. We have big things are aiming at with the opioid epidemic now with COVID-19 pandemic. I'm not scratching my head as much as just we're trying to move in a certain direction with bigger initiatives trying to get people on board. I think with that is one of this pain literacy. Just if we can get more and more people to understand pain better and go, you know what, I got it. I can move on. Then we are doing good things. And so I love being on podcasts and stuff where just, somebody just sits and listens today and 90% of what I just said today is total garbage. And I got this guy's like, but you know what, this one thing is said is really cool. And I can carry that with me. Um, that I think is kind of where we're going. The more people we can touch with this new idea of how pain. That's why Lorimer's coming on. Awesome, way to go! I'm proud of you doing that. Um, but I mean, if I sit there and as soon as I'm done with you, I'm going to probably tell you, "Ooh, you got this problem." No, I got three big boards in front of me. There's a lot of problems on there. I got to try and solve with my teams.
What do you think of the cannabinoid system, both endogenous and exogenous? So the usage of, so for one thing, just like say THC or cannabis, but then getting into psychedelics, getting into say ketamine assisted therapy, kind of venturing into those realms.
Yeah, I don't know enough about it, Aaron, though, be honest with you. I mean, I can tell you I'm way more versed with the endogenous systems. It's not what we talked about today, enkephalins, endorphins, serotonin, cannabinoids is part of it. I'm always going to be a fan of naturally occurring endogenous systems by far, because that's your normal happily occurring. And some people we have to boost it, and that's why but we've seen, unfortunately, what's happened with the opioid system, right? We started supplementing people with artificial opioids, and now we're seeing this major epidemic impact that we're dealing with. And so I'm a scientist. We study it. I'm working with a pharmacist right now on this stuff. I don't know enough to probably have a really good conversation with you about it. I'm intrigued with the idea that if we the more we can move away from these absolutely horrible, nasty opioids that are out there that are killing people by the hour, by the day, I'm all for it. I just want to be always careful that we supplement one thing to another thing. So my claim to fame today is I'm a physical therapist. And so when a patient sits with me and they say, "Hey, Adriaan, what do you think? Should I use cannabis? Should I use etc." My answer is always going to be, in a perfect world, we'd use no drugs, no surgeries, no nothing, right? I want you to go walk, go do your stretches, take your breathing exercises, etc. And I will always be a bigger fan of anything natural that has very little to any side effect. But again, Aaron, just for your audience and for you, this isn't my area of expertise, and I'm always nervous about it because people have very strong beliefs. Either you're for it or you're against it. There's no middle road anymore, and that's kind of sad. I think we should have good conversations where the ill-informed Adrian can sit and listen to somebody teach me more about it. Like, let me find out. Let's see what we do here. But How about I stop there?
Yeah, that's fair. That's fair. All right. So the last piece that you suggested in this like 3-step kind of thing that I heard you just on some other podcast talking about was calming the nervous system, which I think we've been talking about that pretty much throughout the entirety of the conversation. But can we touch on, or can you touch on that a bit of like what are the takeaway actions for a person to start calming the nervous system?
Yeah, as I mentioned earlier, I mean, there's about 22 different things that we have now studied that we've worked in, and this includes things like mindfulness, breathing, relaxation, movement is actually part of both, if you will, for that matter. Goal setting. Now we're getting to nutrition. We're getting into sleep hygiene, and so you can take that whole list, and then maybe the question would be if you had to pick one or two of them. I constantly say if you can get a person with chronic pain to start sleeping better, quality of sleep, duration, you're halfway there. I mean, I would encourage. I don't push anything in these whatever. But I mean, if you go read Matthew Walker's book, just stunning on sleep. I mean, if we can get human beings in general to sleep more, that's my students, that's my own family doctor, my wife, my kids, you, general society, I think the world will be a better place. So sleep hygiene, we spend a lot of time on. Nutrition, we get resources in for people to look at those. Mindfulness is getting incredible research behind it. Pacing, graded exposure, there's a whole list of things people can be doing to dampen that nervous system over time. Non-pharmacologically, by the way.
Thank you so much. I so greatly appreciate you
You're
and
welcome.
your life to be able to have conversations like this. If people
You.
want to go deeper into your work and learn more about you, where should people go from here?
I think two ways. One is if they're interested in any of the stuff we teach, etc. Evidence in Motion is who I work for, putting on seminars, those things. And then I'll publish our orthopedic physical therapy products as patient books, little booklets that people can learn more about pain. So optp.com. Those are the main ones that we tend to get most of our information out. So.
Great. Thank you, sir. I appreciate you.